Good afternoon, I'm Ho. Today I will be your presenter by sharing the experience in thoracic surgery for patients with active COVID infections at my center in Sarawak. The objective of this presentation is to create the awareness in managing preoperative COVID-19 positive patients undergoing the thoracic surgery and to minimize the inadvertent cross-infections among the healthcare worker, optimize the outcome of the surgery, and to serve as a guide for the medical staff involved. Case presentations. A 47-year-old gentleman was diagnosed with category 4 COVID-19 infection, complicated with iatrogenic massive right pneumothorax, secondary to chest tube insertion in early April 2021. Patient proceeded for emergency right wax, clot evacuations, and hemostasis. And there is no evidence of cross-infections among the involved OT personnel despite under emergency setting. This is a graphic presentation showing that 4.22% of the total healthcare suffering from the COVID infections despite completed 2 doses of vaccines, with the majority fall under Cat 2, which exhibit mild symptom, and Cat 1, which is asymptomatic. And this is well documented that the patient undergoing surgery with perioperative COVID-19 infections carries significant risk, with the patient who underwent emergency thoracic surgery with quite a high 30 days mortality, accounting for 42.9%. And elective surgery is best delayed at least for 7 weeks. And this is a flow chart for perioperative management in patients with active COVID-19, which involve preoperative, intraoperative, and postoperative. Preoperatively, patient must wear a surgical mask and cover with a plastic shield. If oxygen needed, nasal cannula can be delivered under the surgical mask. And this is the working flow chart, show that in the person now involved in transferring a patient, full PPE should be done, and the same personnel should be predetermined and allocated to the single patient for all the different phases. And the route of transfer should be predetermined, which is away from the public, shortest possible, and with a fixed path. And then the patient will be called to the OT. Upon arrival in COVID operating area entrance, the patient identifications and the surgery nature were identified and confirmed, and the patient will be placed directly on the operating bed and to transfer to operating room. Once the patients enter the operating room, no staff is allowed to transit in and out, and the lock should be closed and clear alert signal on the door stating that ongoing surgery on COVID patients. And the OT room preferably to be negative pressure setting with a high rate of air exchange cycle, more than 25 exchange per hour for better filtration of viral particle in the OT ambience. And all the medication, instrument, and tray should be single use and ready at OT. And dedicated device to be sanitized after each use. And during the induction phase of anesthesia to be performed by experienced anesthetists with a full PPE donning as shown by the CDC guideline. And PAPR as shown in diagram here. And the IV line should be inserted before inductions, and the modified rapid sequence intubations with any technique is a preferred method for intubations. And the NS should be taking care of this circuit to prevent disconnections, and the ET session should be in closed manner. For surgery, each row of the OT personnel is identified and to choose with the experience and keep to a safer minimum, and to offer a shorter duration operation. And in comparison with thoracotomy with wax, in terms of the risk of transferring of COVID viral to the healthcare personnel, there's actually not significant difference because in the acute phase of infection, there's always having a high viral load. But the surgeons still prefer for minor in wax because of minimal invasive in nature, and also better possibility recovery. If wax is used, the continuous smoke and aerosol removal with filtration is recommended. And for thoracotomy case, a continuous suction system with filtration is recommended too. And after the surgery, all the personnel should doffing their PPE in the designated room. And recovery phase of after the surgery must be done in OR prior to transfer to CICU. And the documentation must be done outside the operating room. And to call the CICU personnel before transfer about 30 minutes before shifting. And portable ventilator should be available and functions. And minimize the staff transport for the patient. Ideally, patients should be designed to be nursed in a negative pressure airborne infections isolation room with a proper meticulous chest drain management under closed and water seal drainage system, and multidisciplinary approach is important in managing the patients. So set of underwater drainage management system important as this is a part of parcel of thoracic surgery. In the closed suction drainage system used with preferable installation of viral filter at the outlet of vent. If the patient uses the underwater seal, so the viral filter is situated between the patient side and also suction port. If there is no suction use, the viral filter bag is used whereby the viral particle will be pulled down due to gravitational force and be deposited in the bag. And if the sterile solution can be prepared by using 1 ml of 5.25% to 6.15% of sodium hypochlorite diluted in 50 ml of sterile water, and shown here with the modified mole with H&E in our hospital setting. So bedside cough test to look for evidence of active and residual air leak should be avoided. And if the chest tube blocked, flushing of sterile water can be tried, but change of the chest tube inevitable if not functioning. Conclusions. During a global pandemic, all efforts should be done to ensure the safety of healthcare workers and patients. Surgery can be conducted safely on patients suspected or confirmed with COVID-19, provided all healthcare workers are adequately donned with PPE to prevent themselves from cross-infections. And all healthcare workers should be adequately trained and skilled in handling COVID-19 patients in peri-operative period, especially understanding the working flow chart as mentioned. These are my references with here. Thank you for your kind attentions.